Okay, guys, if you're happy, I'm going to start. Not all that used to Teams, so I can't really see you guys, so just pretty much myself and my presentation. But let's go for it. So obviously burns, pediatric burns in particular, it's a bit of a, sad, depressing topic. So I tried to associate it with something else a little bit more interesting. So when I thought of the word burns, I thought of the old Scottish poet, Robbie Burns. So if anyone knows anything about Robbie Burns, he's a Scottish hero, and his anniversary of his death is celebrated on the 25th of January, and we call it Burns Night. So as you can see, there's going to be some nice Scottish theme slides coming up. Keep you entertained. So that's Loch Leven. Been there. Right. Nice quote there. Dare to be honest and fear no labor. Seeing as we're about to work, let's get to it. So important with burns patients, and pretty much any trauma patients, in fact, we want to get a good general history first. That's typically going to come from your sample history that your EMS handover is going to involve. You're going to have past medical history. You're going to want to look for or ask for any comorbidities, allergies, any medication they might be on that might predispose them to complications further down the line. Mechanism we know is important. If this is a patient that sustained burns, what burns? Was it flame, scald? Was it a blast? Could there be secondary injuries? Could there be inhalational wounds? So we just got to think about that, treat the patient holistically, and as we know, follow ATLS principles. They love saying that, and sort of taking it one step at a time. First aid's important in burns. Can anyone tell me, I'm not going to pick on anyone yet, how long we should cool under running water for? There is a time that they recommend. Marie-Louise, I'm calling on you. Anyone?
I'm struggling with my microphone. Can you hear me?
Yeah, got you.
Okay, I don't know.
I'll give you a multiple choice question.
20
10,
minutes.
20 or 30 minutes.
20.
Good. Yes.
20,
so
24.
I was quite surprised. Like
Okay.
I was thought, like just running on cold water for a little bit and then, get on with it. But they, like every single resource I've looked at, has said 20 minutes. They say avoid hypothermia as best you can, but it's one of the best methods of reducing further burn and preventing essentially the penumbra of the burn getting any worse. Is just cooling under running cold water. So they say if that hasn't happened sufficiently, you can even continue that in the hospital. Typically, we know they come in covered in burn shield and no one's ever run cold water over them. So theoretically, we should be doing it with that cold IV fluids. We can do it as well. Obviously, like we said, ATLS principles, airway. This talk, we know burns is a massive topic, so I don't want to go too much into the depth of airway management in a burns patient. We know it's a difficult airway. You need to think about it. You need to act early. The breathing, again, that mechanism on the history is important. Were they in an enclosed space? Could they be at risk of cyanide, carbon monoxide? So not just the inside of the airway could be a concern, the chest wall as well. We know if they've got a full thickness injury, could they have contractures? Is there a need for an escherotomy? Things like that. So it's not just the inside, think about the outside as well. Anything that could affect your ventilation. Circulation, we know burns are at high risk of reduced cardiac output, the SIRS response. They need significant resuscitation in that regard, especially if they're moderate or severe burns. GCS, could there be associated injuries, other pathology? If their GCS is low, check a sugar. In babies, we know any critically ill child, they're high risk for having hypoglycemia. Yes, the burns itself, we're going to get into that in quite a bit of depth. And then remembering temperature. High risk for hypothermia. We've got to do everything we can to try to prevent that. As we know, it's just going to raise our mortality significantly. So burns, we know. We need to know what type it is, how we can manage it from that side. Obviously, management is different for specific burn types, body surface area, and then depth. So types, we've got scald, flame, contact, friction, chemical, electrical. Only thing, I mean, we go through this many times. It's pointless going through it again. Important things there is that when they say friction, just like someone that's unfortunately been maybe dragged by a car or something like that, we know deep abrasions should be treated like a burn. Just on a side note, other things treated like a burn, we know like our Stephen Johnson's and our toxic epidermal necrolysis, all of those things should be treated like a burn. So if a patient's presenting with that, sort of same management principles apply. Okay, another Robert Burns quote, suspense is worse than disappointment. Put this in because now we're going to get down to the nitty gritty. Okay, who knows what this is called? I can't hide my screen. It's on the top of one of the charts. 3 points there, guys.
Well done, Holly. Might be a London Browder chart.
Oh, well done. Yes, that was fantastic. So I put 2 in here because as you can see, the one on the, what is it, the colorful chart, it shows quite sort of clear numbers, quite easy to use. And then you've got the other one on the sort of black and white one that gives a really nice, clear breakdown of age, different percentages. I think these are fantastic charts. They're recommended. They must be used. Often the pitfalls of burns management is over or underestimation of the total body surface area, and therefore leading to over or under fluid resuscitation. So it's really important that we get it as accurate as possible. So the gray one is best to have, but obviously difficult to use. So it's the kind of thing you would want printed out and easily accessible. However, modern technology has allowed us to have multiple apps on our phones that can help us with burn surface area estimation. So this one was recommended by Brad a few years ago. It was, the only downside, I believe, is this one is in French, but it was really user-friendly, and you can just assess the burn wound, you plot it, and it gives you a whole bunch of parameters. There's multiple other ones. I had a look through on, sorry, I'm an Android person, so on the Play Store, and there's multiple, and like most of them are free as well, and they're very, very useful because they give you all these other scoring systems and the scores of them for you, which is very nice. So depth, again, we know depth very well. We've been through this many times, but just a recap, superficial is just erythema of the skin. There's no blistering, there's no loss of any epidermis or anything like that. We've got a superficial partial, very common, see them often with our scald/hot water burns. You'll see there that the base is nice and pink and likely to blanch. We've got a deep partial, they're white base, unlikely to blanch, less painful, still pain, but just less painful. And then you have here can everyone see that? I don't know, can you see this little bar? Is it, I don't know what's presenting or not. Sorry, I've got this Zoom bar in the way. Okay, anyway, so there's just over the dorsum of the hand there, you can see that full thickness burn. It's thick, leathery, and it would not be painful. Right. Let me move on. Right, another nice quote here. I would try to do it in a Scottish accent, but I'd only embarrass myself. Right, so let's get on to nature's fire. Fluid resuscitation. So bread and butter here. We know Parkland's formula. Often in adults, we know we often over resuscitate with a full Parkland's formula of the 4 mils per kilogram per body surface area. However, in kids, pretty much everywhere I read said 4. Some places said 3 to 4, but none of them really used the 2 mils, the modified Parklands that we're using in adults. Does anyone know what the Brooks formula is? I will pick on someone. Rob. Anybody?
Heard of it, can't remember it.
Perfect. So all I could find is it's basically the modified Parklands as we know it. It's the 2 mils per kilogram per total body surface area. But again, very rarely referred to. Pretty much every source that I looked at, be it international guidelines or up to date, it was Parkland's formula was recommended as your initial resuscitation. And we know first half in 8 hours, and second half over 16 hours from the time of injury. So then we need to think about maintenance, obviously in children. Again, we've already spoken about the risk of hypoglycemia and the need for maintenance fluids. Typically maintenance, we know the 4-2-1 rule or the 150-20. If anyone's unsure, shout, but I think we all have been through that a few times. And
Ollie?
then, yes.
That's Yvonne.
Yes.
Just about the books modified, what I've read is for adults 2, for kiddies 3, and for electrical it stays 4.
Okay. That's
But
helpful.
yeah,
Yeah,
depends,
so
I guess, what you read.
we used 3 mils per kg. And obviously, depending on how the patient is doing and responding to the fluids, because we often are stuck with these burn kids for a long time before we get them out to other facilities, you might need to go up or down. Yeah.
100%. So that comes nicely into how do we assess their response to fluid. Anyone want to give it a shout? Fluid responsiveness, assessing fluid status in a patient? In a pediatric patient? Lorata? Trying to remember all the names.
I think you could possibly, I know it's peds, possibly use an ultrasound and do frequent checks with ultrasound, but urine output monitoring is probably best for them. Accepting a much higher urine output monitoring in the pediatric population. I think it's about 1 to 2 mils per kilogram per hour.
100%. So what I've read as well, please, anyone correct me if it's wrong, 1 to 2 mils per kilogram per hour if they're less than 30 kilograms. If they're greater than 30 kilograms, it's 0.5 to 1 mils per kilogram per hour. Typically what we look for in an adult. Then they go further to say, I know we're talking peds burns now, but then they talk about adult burns. They would tolerate 30 to 50 mils per hour regardless of their weight. So they're in adults slightly less, just like you said there, that they recommend a higher urine output for pediatric patients. Yep.
Can you just repeat the weight difference in the peds one that you said earlier?
So less than 30 kilograms.
Yeah.
1 to 2 mils per kilogram per hour.
Cool.
And then greater than 30 kilograms is 0.5.
Perfect.
1.
Thanks.
Right. So obviously urine output's 1, sonar's 1. And then in kids, vital signs. What vital signs help us more in children with regards to their fluid status? Anybody?
Well, I guess we'd go with cap refill rather.
Yeah. And on the monitor?
mentation. Yeah, not sure.
This one's hard because they typically say that's pulse. So blood pressure in babies, as we know for ATLS, like any sort of trauma, or children, their blood pressure will deteriorate much later on. So they say try target your pulse, your heart rate, but within reason, as these patients are likely to be in significant pain. Say now you've administered your Parkland formula, you're doing everything by the book, and they're not responsive. You've gone maybe, let's say, 18 hours. You're not getting what you feel is adequate in terms of your endpoint targets. What should you consider if they are fluid unresponsive?
Minor drops.
Yeah, okay. So in the interim, yeah, consider some sort of isotopes potentially. But in terms of is that all that could be wrong with them? Should we think broader? Have we missed something?
All right, that's where you're going.
Probably not a very clear question, sorry. But that's they do, yeah? Anybody? No?
I think there's something called like a Burns syndrome. And in these patients, you can possibly consider giving albumin.
Leave it. Leave it.
I'm hearing a lot of leave it.
Someone's not muted.
Burns syndrome. I'm not gonna lie, I didn't read up on that one. I might have missed that. If you know more about that, Lorato, let us know. Yeah, that one's definitely skipped me there. You still there? Okay, we'll move on. But again, comes back to mechanism. Was this patient a burn and then a fall? Could there be occult injuries? Could they be bleeding elsewhere? And then the other thing that comes up is, should we be using hyperosmolar fluids or not? I'll go on to that a little bit more because I go into more like the crit care, that typical patient that is going to be staying with us longer, and how we manage them further. Feeds. I think anyone that's worked the peds burns ICU, not everyone has, but if anyone has, you know how important the feeds are. Does anyone know the recommended time to start feeds in a pediatric burns patient is? The time frame. Isak?
I'm not sure about the time limit, but I would say as soon as possible.
Yes, that's pretty much what they say. It's as soon as reasonable. Again, critically ill patient, if they are requiring inotropes, is systematically or hemodynamically unstable, then you do want to hold, as we are aware that their enteric perfusion may not be sufficient. So if they are more stable hemodynamically, then yes. The recommendation that I found was within 24 hours. Then some, depending on the institution, was 6 to 12 hours in. So again, comes back to how often are these patients with us longer than they should be. And typically they're going to be getting into that time frame of we need to be considering feeds. Right, moving on with regards to fluids, wound management. This is emergency care. We're doing it pretty often. So obviously we know the importance of debriding our wounds, be it superficial partial that's blistering and we need to de-roof blisters, or full thickness where we need to consider things like eschorotomies and managing those potential complications. So debriding. How is it recommended to debride our blistering burn wounds? Anybody know what solutions or fluids we should be using to wash off the skin? There are recommendations. This was new to me. Meg?
So something warm, like a warm saline. I'm not sure what the exact recommendation is.
So again, different resources, but 100% warms, if like that's what you've got, warm saline's fantastic. Other places recommended a mild soap. They weren't very specific, but then I found one guideline that was incredibly specific, and it was the chlorhexidine gluconate. And it had to be, so typically we get the 5% solution, and it had to be specifically diluted down to 0.1%. And the whole guide, it was the New Zealand guideline. I put it in the end of my references, how they recommend to dilute it down. So yes, saline, sort of clean, sterile saline or sterile water, nice and warm. And then if available, a mild soap. Ideally that sort of antiseptic one like a chlorhexidine. Dressings, okay, that's a whole topic. I've got another slide on that, so we'll move on there. And then tetanus, don't forget your tetanus. In children, obviously we've got to be aware of our immunization schedule. If they are up to date and they're less than 5 years, they should be within. However, they might be a little bit out of that. That's just something that we need to be aware of. Hopefully the caregiver that might be present will hopefully know the immunization schedule, but as we know, if in doubt, just give. Okay, escherotomies. Okay, so we know that they are indicated in full thickness wounds. It's burn wounds. They are indicated more so in the acute phase if they are circumferential. And why? What are the potential complications of full thickness burn wounds? Z.
Full thickness burns, so especially within the trunk chest cavity, they're going to cause difficulty in ventilating the patient, and thus they'll come in possible respiratory distress failure just because they're not able to inhale, essentially. And so that's why we do escherotomies for them.
And if it's on the arm?
Oh, the compartment syndrome.
Yep, 100%. So difficult to identify initially. So be on the lookout. Typically, we know that we'll do almost prophylactic escherotomies if they are circumferential full thickness burns. So difficult question to ask talking wise. So I'll show you a nice picture of where the cut should be made. This is a very simple drawing that someone's done, but it's incredibly useful. The concept is wherever you're going to make your cut, it's on the lateral midline, sort of lateral longitudinal aspect of the body part. So as you can see on the chest, a bit difficult. They go around sort of in the armpit with that upside down V transversely, exactly like Z said. If you're getting ventilation difficulties, most likely these patients are significantly critically unwell and they've already been intubated. You might be noticing high pressures, difficult to get the adequate tidal volumes, and having noted significant deep burns to their chest. Other thing I read was that on the fingers, they say be careful. This is, anyone wants to chime in here, happily hear it, but they say you want to go on the lateral aspect of the fingers like it shows there, being careful of potential incision sites where they might do Z-plasties, which I imagine are more over the palmar aspect of fingers, especially if the patient wants to get contractures. Right, so big hot topic. The articles and the research are endless as different companies are bringing out different dressings and what's better than what. Obviously, different settings will have different availability, private, government, first world, third world. We're typically exposed to Gelinet and Flamazine. Does anyone know the active ingredient of Flamazine? KB.
Is it not silver, sulfasalazine that's in Flamazine?
100%. So can you give us any benefits of Flamazine? And so pros and cons, anything. The reason I'm asking is because we know it's quite widely available, especially in our local CHCs.
So familiarity, a lot of the nurses seem to be familiar with it. But I know that silver does have some antimicrobial properties, which is why it might be preferential with burns in the long term. Yeah, that's as far as I go.
Any cons? Any contraindications?
Cons, just from an application perspective, it can get a little bit messy and slippery. And I don't know of any contraindications.
Cool. Anyone else? Does anyone know? Because I didn't. This is what I'm asking. It was new to me, I must admit.
I think if they wanted to bride further or want to do a skin graft, it becomes problematic because to get it off again is a problem. Yeah, so I know the surgeons don't necessarily like it because it's really difficult to then do a graft on it.
So my understanding as well is that any sort of the ointments they can also affect the total body surface area or thickness estimations at the arrival of a burn center. So 100% it can affect the further management of the wound. But the other thing is, especially in pediatric patients, so typically infants, young babies, they actually don't recommend it. But again, I looked in the pediatric EDL, which is our South African guideline, they did recommend it, but they did say keep not around the eyes, not on the face. It's toxic if it gets in the eyes. So it must never be put around the eyes. That's why we typically will put some sort of eye ointment. And we know we usually use chloramphenicol. But also pregnant or lactating mothers, they don't recommend flamazine, which I was not aware of. And given that it is something that is widely available, that was interesting for me. But yes, they typically say if you are in a first aid or sort of a primary healthcare facility, any sort of moist, non-adherent dressing is optimal, especially if this patient is going to be transferred to a burn center. Exactly like Yvonne said, that further management by the surgeons can be affected by these different ointments that could be put on. The ones that I'm aware of that we have available is pretty much just flamazine. Does anyone know what a DAC-containing dressing is? I can give you a clue. They're using it at Alberton. I didn't know it. Anybody? No one? Okay, so it stands for a really long thing, like alkyl carb boil something. It's basically a very interesting. It's one of the green dressing. I've got it on the next slide. Once you see it, it's very nice. It's saw backed, but it's a very nice dressing in the sense that it doesn't contain any ointment or anything special. It's just the mesh itself has this hydrophobic molecule, which is the DAC, and it causes the bacteria to stick to it. So once it's stuck, the bacteria is no longer functional. And the idea, it's very good at infection control and preventing infection, as it just attaches, attracts, and neutralizes the bacteria. It's also, once it's put on, it's like the primary layer on the wound, and it's left there. You keep it there for a few days. If there's a bit of exudate or a little bit of maybe even a more exudate, because if it's pussy, if it's sloppy, it must come off. But if there's a bit of exudate, you can make a little hole, let that exudate out, and you cover it with dry gauze over the top, and then you bandage it on. And the dry gauze and the bandage gets changed, and the Sorbact, the green stuff, stays until it starts to sort of slough off on the edges. Hydrocolloids, there's multiple. Again, that New Zealand guideline was very keen on the Mepitel, Mepilex. These typically were silicone-based. There's gels. There's lots of different types. Again, there's a Granuflex, but basically it attracts the exudate and it forms a gel, and it maintains that moist environment. It maintains that contains sterile environments, ideally as well. Foams, highly exudative wounds. Foams are more recommended. You get silver containing, non-silver containing, and then your more fancy biosynthetic. Sorry, the one thing I didn't mention was Acticoat, because we do have access to Acticoat. Does anybody know anything about how to correctly apply Acticoat and when to apply it? Who can I pick on? Marie-Louise, again?
Okay, I know you have to wet it with sterile water and then apply gauze over it. That's what I can tell you.
When can you apply it? Do you know anything about that?
No, I don't. I'm not sure, no.
When have you applied it?
I haven't personally applied it.
Okay. So the first time I actually used it was at Tumber. They've got it in like sort of ready supply, sorry. And yeah, you use it like we would have used our Gelinet. You clean, so you debride your wound. Obviously, good analgesia for our pediatric patient. We debride nicely, clear it off with our nice mild soap or sterile water or saline, and then that's exactly it. You just wet it, and you then apply it just like a Gelinet in the acute phase.
I've been told not to wet it with saline. Do you have any input on that?
Yes, no,
I don't know why.
sorry. I don't know if I said that. Yes, it must be with water. They say that the chloride in the saline can bond with the silver particles, and then less silver is available. Because the way it works is once it's wet, that silver is available or active, and then that's the silver that will denature and kill bacteria. So that's why you've got to, yes, you're 100% right. Sorry, it's water, sterile water. And then once it's on, I believe it can stay on for 48 hours, if not longer, maybe up to I think it's up to 5 days. And then the dry gauze over the top, then covered by crepe bandage, can be wet again. If it gets dry, there's less silver ions that are active. So when you wet it again, it's continues its action. It's nanocrystalline silver is how they term it. But yeah, does that answer the question?
Yes, thank you.
Okay, cool. Right, does anyone know any of the really fancy expensive stuff? Has anyone ever heard of BioBrain? If you have, just shout if you've ever used it. I'm curious because I haven't.
I've heard of it, but I've never used it.
Okay. So I heard it like it is used in private. I think, and it's typically, I think, used after a couple of days. The wound is re-cleaned, re-debrided, and then it's applied. It's a mesh. So I've looked it up, so a bit in depth, but a nylon mesh with silicone over the top, and that nylon mesh is impregnated with porcine collagen. And it's a transparent bandage, or sorry, a transparent dressing that is applied to a clean wound. And what it does is that collagen causes the fibrin and the exudate to all become basically a scab, and it's all completely adherent to the burn wound. And as the burn wound epithelializes underneath and heals, it heals from the edges, and that BioBrain slowly sloughs off. And again, the dressings on top, like a dry gauze or a crepe, are changed. The BioBrain stays on. It's one of your temporary skin substitutes. It stays on for up to a week, and you can just trim the edges as the wound heals, where it sloughs off. Lots of different dressings, a little bit overwhelming. I think what's important is where you're working at the time, work out what is available and what is recommended by that facility.
I have a question.
Everyone's got a preference. Yeah, please.
Acticoat. Is it not similar in that sense that when you put it on, you're actually supposed to wait for it to lift off? Or do you take it off?
Not in my reading. If anyone wants to say anything, I know. As far as I'm aware, it's one that you change. Yeah.
I also thought that you don't change it.
Adheres,
it's just
you don't
trim
change
the edges and it comes off. But
I
might be
remember
wrong.
from Ciba King that we used to put it on the kids, and they used to hate us because whenever it was time for dressing changes, the nurses would rip it off, and it literally would rip their skin off. You're supposed to trim the edges, the same like you would with BioBrain, I think.
Okay. I'm unaware of that. I'd have to look that up, because my understanding was that it's put on, and it stays on for up to 5 days, and you just have to keep re-wetting it. But it's not termed one of these skin substitutes like the BioBrain. But again, I'll check that. I'm not aware. But very good question. Because the Sorbact as well, which is this green, I don't know if you can see my cursor, but it is this green one right up in the middle at the top. And that's, like we said, that's the adherent one that gets trimmed at the edges, just like the BioBrain. Maybe like the Acticoats. Honestly, I'm sorry if I didn't know. And then it just stays in place, and it just gets trimmed as we heal on the edges. But yeah, no, Good question. Sorry that I can't answer it. And then all the other ones are like foams, hydrocolloids, fancy stuff. But yeah, I think, like I say, also, if you are slightly further out and then you're referring in, nice to know the burn center's recommendations, like Barra burns. I mean, we all know, like working in Barra itself, you're just using Gelinet. I don't know if anyone has any experience of what they actually dress their wounds with once they're in the burns unit. I'm actually not sure. Anyone?
I actually just saw them using normal kind of Gelinet dressings, which was quite strange in peds burns. Every time they changed the dressings, they would kind of just put normal dressings on. I don't know.
Okay.
I don't know. Maybe I didn't see that properly. Maybe I missed it. I don't know, because I didn't really see them use any of these dressings.
I didn't either when I was there. I didn't. What I did see was, unfortunately, like just peds burns ICU, which is they've been there longer and they're sort of more onto our grafting stages, but which we'll get into. But yeah, no, I didn't see any of these fancy things, which was just a bit of an eye opener for me. Again, importance of getting used to what your facility has available and uses. And this obviously definitive cover. So when the wound is ready, when the surgeons are happy, again, typically not going to be in the ED, but if you are heading into critical care someday and managing a burns ICU, you'll be involved in when they're using what. Does anyone know what xenografting is? Who can I pick on? I've forgotten who's there.
Meg will try. Isn't it if it's an animal skin graft? Because xeno tends to mean animal.
100%. So just different species. Yep. So graft from different species. Typically we use porcine, pig. Obviously just importance there of anyone's cultural beliefs. That could affect their choice of consent to that. An allograft. Anybody?
Same species, different person.
Yes. So typically like a cadaver skin graft. Autograft is obviously there. Same species, same person coming from them. The first two typically are in a way sort of temporary skin cover or closure, because both of them the body will eventually reject. But the idea behind it is almost like the BioBrain, is it's a temporary skin substitute to allow that epithelialization, whatever, the healing, the granulation underneath, to improve the pain and just stabilize that wound. But autografting, as we know, skin grafting from yourself, is a much more definitive closure or wound cover. Has anyone ever heard of the ReCell machine? I hadn't. I was asked to talk about it, so I had to look it up. It sounds fantastic, by the way, if anyone knows about it. Skin spraying machine.
Isn't that where they make your own skin and they basically spray it on, but they use stem cells or some part of, yeah, I know. I think a guy, it's an Italian surgeon in Durban, was a guy who not pioneered in South Africa, but he is heavy into it. Yeah.
Awesome. Yeah, that's exactly what I've understood about it. So it's a little machine that it has to be used by someone that's trained to use it. And they typically take they even called it a biopsy of skin, like a 2 by 2 centimeter graft of skin. And they run it through the machine with some enzymes, with a fluid and all of that. And it breaks it down, and exactly that, they spray it on. There's a lot of, it got a little bit intense as to when you should use it, when you shouldn't. Is it partial thickness? Should it be in association with like a meshed autograft? But there's no consensus there. but what I thought was really interesting is 1:80 ratio of coverage. So what they said is if you had a 2 by 2 centimeter graft taken, once it's run through the machine and it's sprayed on, it's like 320 meters squared. It's like exponential amount of skin that it, or wound that it can cover. So it looks very promising and likely very helpful in our patients with quite significant, extensive burns. But like I say, whether it's deep, thick, or full thickness or deep partial, there seems to be a bit of debate there. But again, this is not really for the ED. This is like what's further down the line if you are managing a patient in a protracted time. Just another little quote there.
I'm going to jump in as well. Also important, I think, for you guys to know about if you're working in the private setting, because you'll have patients with severe burns coming through to the private burns units, and your trauma surgeon or your plastic surgeon very well might be talking about different things, and getting good coverage in theatre as soon as possible.
Awesome. Okay, so taking it one step further, patient's been there a while, and we need to kick off our critical care. So obviously burns patients, there's significant risks for further down, so organ dysfunction. We've spoken about how they can have reduced cardiac output, they can get a SIRS response, they've got these fluid leaks. They're also prone to complicate with the hypermetabolic state. Again, anyone that's worked the burns ICU, it's persistent. So after about this sort of phases of it, it starts with the ebb phase, which is in the first 24, 48 hours. They actually say that a patient, significantly burnt patients, cardiac output will reduce. They will have almost a depression of their physiology. But after that, after 48 hours, they go into this flow phase and they become tachycardic, hypertensive, they become catabolic, and this persistent hypermetabolic state can continue for up to 2 years, like 12 months post-burn. And that catabolic state can continue for up to 3 years, I believe. It's significant changes to the physiology that can occur. So the importance from our perspective, an emergency department or potentially one that is continuing that initial critical care, is how can we attenuate, how can we calm this hypermetabolic response? Does anyone know of any way, like any interventions that we should promote or be aware of that can help us in this regard? Bit of a tough one. Anybody? Okay, so what my sort of reading noted was that I'm trying to just get like the list here. So the big one is early burn wound excision. So debridement from our side, and if it's a full thickness burn, that early burn wound excision by the surgeons is incredibly important. So trying to get this patient to theatre would be from our perspective. The idea behind that is it reduces that burden on the body, that foreign, because it becomes foreign tissue that the body needs to fight and essentially fix. Aggressive pain control and insulin to maintain normal glycemia. Insulin seemed to be a very important concept or management in these patients with regards to this catabolic state. They increased glucagon, they use up their glycogen stores, they become hyperglycemic. So the insulin management is incredibly important. Vitamin C. So the reasoning behind vitamin C, high dose vitamin C in some studies has shown decreased fluid requirements and improved outcomes. However, there's differing opinions. So that's going to be one thing that might be in conjunction with your local specialist, your local whoever you are consulting to help you manage this very difficult critical care patient. Fluids, we've spoken about the initial stage of fluids, that Parkland's formula over the first 24 hours. Is anyone aware of when we should or shouldn't be using albumin in our burns patients? Again, quite conflicting opinions. Anybody?
I don't know the right answer. I just know that they give it quite frequently in Peds Burns ICU. Like all of them are on albumin. So I don't know what the correct answer is.
So again, from the reading, it seems to be that in the past, when they first decided on Parkland's formula, the recommendation was you complete Parkland's formula, 24 hours, and you then immediately give albumin. And the idea, it gets a bit complicated. It's all about this thing they talk about called fluid creep. So these patients are getting significant quantities of fluid to resuscitate them, as well as maintain them, as well as medication. And medication is put in fluid bags, and you slowly creep up your fluid that you are administering to the patient. And the thinking there was that after 24 hours, you've given your resuscitation, you give a hyperosmolar fluid to help draw that fluid from the interstitium that's leaked out back in. Very conflicting research in like the 70s, 80s. They said higher mortality, so people stopped using it. However, now there seems to be better morbidity and mortality outcomes, and it's starting to creep back into guidelines. The only local guideline that I could find that was, like I say, South African, was the pediatric EDL. And what they recommended there was the use of albumin if the patient was a symptomatic hypoalbuminemia. So I imagine there this patient was very edematous with a documented low serum albumin. They would then, the recommendation was then to give, so I just want to get the dose right, 2 grams per kilogram per day. That's the albumin 20%. And this in the 20%, 100 mils is equal to 2 grams. So that's just one clear recommendation I found, because a lot of the other recommendations were very sort of center dependent, was the sort of final conclusion. So that was a bit of a tough one from my side.
And it's also tricky. Yeah. It's also tricky because albumin is an acute phase reactant, so it's going to go down. And these patients are notoriously malnourished, right? So their albumin is also going to go down because feeding them can be very difficult. So you will find that it is clinician dependent and center dependent. Just remember that in South Africa, we do not necessarily have 4 or 5% albumin. And overseas, so in Australia or Australasia, other places, they very well might have the 4% solutions, which can be used as resuscitation. And the benefit is therefore, even if you're using albumin, we don't necessarily have to use as high volumes of crystalloid. So that also spares the patient from fluid overload and lung pathology, ARDS, subsequent to all of our significant fluids. So unfortunately, the literature is very conflicting. As you said, in the past, the mortality was much higher. Anaphylaxis was big. Also how they prepared the albumin, who were much more likely to get infections from it. But now the mortality seems to be fairly equivalent. So there doesn't seem to be an increased mortality with using albumin. The main problem in our setting is the cost. So it is a very, very huge cost. And it can't just be given because the albumin is low. We have to give it for a very sort of specific reason, like our edematous patients.
The other hyperosmolar fluid that is mentioned in the articles is hypertonic saline. Again, the idea behind that is hyperosmolar intravascular state to help draw back in the fluid that's leaked out into the interstitium. Again, very conflicting response to that. The only thing that I found, it was, again, center dependent, and it mentioned that the positive outcomes was that it decreased fluid requirements, and when it decreased the tissue edema, it was only in the normal tissue. It didn't decrease tissue edema in the burnt tissue. And that seemed to be the conclusion to most of the hyperosmolar fluids. So that included albumin, hypertonic saline, the Voluven, hydroxyethyl starches, and the FFPs, plasma. So again, give if indicated, but differing opinions. The only one that seemed pretty clear was do not give Voluven. That showed worse outcomes. I believe it was worse mortality. So that's a no. But the others were maybe center dependent. And so just the last point that I've got here is diet. We've spoken again, feeds as soon as possible, ideally enteral, NG tube. Reason behind the NG tube isn't just if they can't drink, they're critically unwell. It's the volume that's required to maintain their dietary requirements is massive. Typically, they don't tolerate it, so it's better to be given in a continuous infusion over 24 hours to allow them to get the significantly high requirements. Does anyone want to go try this? Pretty much going to be close to the last question. Should you give them more fat or more protein? Anyone want to try it?
I'm going to say protein.
Yes, 100%. And what do you think about the fat? Do you know anything about fat in the diet of a burns patient?
No idea.
So they typically are lower fats. I read a whole section on it, but it showed worse outcomes, the free fatty acids, certain metabolism. I apologize, I've forgotten the intricacies of it, but it's rather reduced the fat quite significantly, and it's protein, and you need quite a significant amount of protein and then carbohydrates because of this catabolic state they're in. And on that note of food and diet, can anyone tell me what's in this picture on the screen? Scottish delicacy.
Looks like
I was going to say it was a spud, but
maybe not the best picture, but it's a haggis.
Okay.
It sounds disgusting, but it's actually delicious. But anyway, right. So risk stratification. I probably should have put this sooner. I apologize, but comes a bit further down. And like any management of our patients, we need to risk stratify where we're going, how, what sort of severity do they fall into, what's our possible disposition, etc., etc., etc. So the Bow score. Anybody aware of the Bow score? I know I'm asking a lot of questions, guys. Just trying to keep you away. I'm going on for a while. Sorry. Almost finished. Bow score? No. So Bow score was quite interesting because I take it as it's kind of what we're doing clinically, but someone's actually given a name to it. So it's the Bow score itself is age plus total body surface area. And that added to each other to try and give you an indication of the potential mortality of the patient. Then they revised the Bow score, age plus total body surface area plus 17. And if it was 140 greater than 140 to 150, significantly high mortality, and therefore should be palliative. Obviously, in our setting, we've heard anecdotal things that you take 100 minus their burns percentage, and that's their chance of survival. I found no score that is it, but we know the greater the total body surface area and the greater the thickness, worse outcomes. The ABSI is the abbreviated burn severity index. It includes 5 variables: age, sex, the presence of inhalational injury, full thickness injury, and the total body surface area. Gives you scores and then different severities amongst that. A lot of those burns apps had the ABSI calculated once you input the burn size and depth. It seems to be quite important overseas. If you are referring to a burn center that has strict protocols, they may add the ABSI as a parameter to see if that patient requires transfer or not. The flame score, this one, it's talked about a lot in a few articles that are looking at the comparison between flames, ABSI, and the bow score. And they said the flames has a fantastic sensitivity and specificity, better than all the others. However, I try to find the flame score, and it's a very long calculation. It's calculations, it's numbers, it's using coefficients. It uses the day one Apache score. It is not user-friendly. To even find it was very hard. It's not on MDCalc. It didn't appear anywhere else except these comparison studies. So I think in reality, the one that actually seems most user-friendly and most applicable would be the ABSI. It seems to be used quite significantly overseas as well. But that's that. What I found here was just a very nice, this is a more, primary healthcare one-page approach to management of pediatric burns patients. Just a side note, this website here, I don't know if you can see it right at the bottom, it says www.pedscases.com. If you're unaware of this website, which I was, it's fantastic. It summarizes pediatric conditions into one page. It's got quizzes, it's got multiple choice questions, so a very nice pediatric study tool. So that's there. This is pretty much it. So are there any questions? Is there anything I haven't covered? There's a few things under critical care, like the use of vitamin C and vitamins, that I didn't touch on. But
how does zinc help me?
I did not read up on that. I apologize. I can't answer that. I'd have to read that up for you. I'm sorry.
No, that's
Anyone
fine.
can answer that, I'd be very grateful. Yeah. Mine is, so zinc typically it's just like an immune booster. But yeah, like we know in peds burns ICU, it's zinc, it's vitamin C, it's iron. The one thing that I did read that was quite important is if you are giving iron supplementation, it must be stopped if the patient becomes septic, as that helps proliferate the bacteria instead of helping the patient. So that was something with regards to vitamins and crit care that I did read about. But yes, I'm sorry, I can't answer thoroughly on the zinc.
All good.
Any other questions,
Holly,
please, if I'd read it? Yeah?
thanks for a very good talk. I mean, burns is such a big topic. I am gonna share some things on the group. When I was an intern, I worked in Maritzburg, and we worked under Nikia Lortu, who was the president for the Pan-African Burn Society. She is the founder of the Burn Care Trust, and they have their own website where they go quite deep into like dressings, analgesia, nutrition, how to manage burns in the ED, and then obviously when they're in the ward. And I found it very useful whenever I have a burn to go back to that website and just look at key things. And then obviously on that website also, if you want, you can buy the like the courses for, I think it's $500 or 1,000, and then they donate that to their trust so they can continue their burn service in KZN. So yeah, I'll share that on the group.
That sounds fantastic. Thank you. Yeah, I hope what I've mentioned correlates with their guidelines. I must admit I didn't come across that in my Googling, but I know about them, and they're doing fantastic stuff in PMB. Anything else? Any input? Anything that you would have liked me to have touched on that I might not have, that you've maybe experienced managing a burns patient?
Can I ask a question?
Mm-hmm.
What is the role of burn shield?
So my understanding is burn shield is just a first aid measure. It's temporarily, like very temporary cools the burn wound. And that's it. Ideally, once that burn dressing is warm, it needs to come off because it will then continue that burning. It doesn't continuously cool. So it's quite actually a limited role. It's a first aid tool. That's my understanding.
Any problems with it?
I'm not sure, but I don't know if maybe some of the compounds can cause issues to the burn wound that can be actually slightly toxic to the burn wound.
Anybody else?
Can also cause hypothermia if you leave it on for too long.
Sure. Can cause anaphylaxis itself. The tea tree itself on the skin is not an issue, but a very large volume can be inhaled, the oil itself. And if there's a large volume, so if you've got a very big percentage burn in kids, the inhalation can cause an issue and then actually can be toxic if it's ingested. So tea tree oil itself, when there's large volumes, if it's ingested, now, fortunately, we don't make them eat the burn dressing, right? But the inhalation can be an issue, and it also has potential toxicity as well. So it's not a favorite for kids. Take it off when you get into a facility.
Thank you. Oh, that's my last line. Go get him.
That was awesome. Thanks, Holly.
No, thanks, guys. Thanks for your input. I really do appreciate I know I didn't really see your names and I sort of fired questions at you, but and really thank you for sort of the input and correcting anything that I might have not got quite right. But those are the main things I use. That GDL one is that New Zealand one, that New Zealand guideline that was quite useful. And that's it.
Thank you so much, Holly. That was awesome.
Thank you,
Thanks,
Holly.
guys. Cool. I don't know how to edit it.